For years, diabetes care has relied on A1C testing to measure average blood sugar and guide diabetes treatment, and this approach has established the importance of glucose control. But A1C alone does not provide real-time insights or help patients and clinicians manage daily fluctuations in blood sugar. Now, a new array of tools and technology is doing things to improve diabetes care that A1C measurement does not. I'm Andy Reynolds. On this episode of Quality Matters, we learn about the new era that is dawning in diabetes care. Our guide is one of the leading architects of this new approach.
Hello, I'm Rich Bergenstal. I direct the International Diabetes Center, a great team of researchers and clinicians in Minneapolis, Minnesota, trying to help improve the lives of people with diabetes.
Rich, when I told a colleague that I was speaking with you today, they said, "Ooh, Rich is famous in diabetes care." Why do you think a colleague told me that? Or what do you think you are famous for in diabetes care?
I think your colleague didn't really mean famous. I think he or she probably meant he's persistent. He's been around a long time.
Persistent at what? What have you been focusing on in diabetes care for a long time?
His mission to see people get the best possible care. People with diabetes are really curious. I have high blood sugars. When do I have them? What time of day? What does it look like? So we've looked from measuring your average glucose for decades to poking your finger to actually see your blood sugar to now having continuous look at your blood sugar with continuous glucose monitoring. I think it's opened up a whole new of confidence and treatment and approaches to better care.
We'll get to continuous glucose monitoring in a moment, but I should let our audience know that you and I worked together on an NCQA webinar in October 2023 about diabetes care. And you mentioned something that day that has always stuck with me. You said, "We're living in the era of A1C." I was hoping you could explain why that's true or why you think that's the case.
Oh gosh, Andy, it's a funny thing. My career has been quite long now. The first 20 years has really been establishing that good glucose control matters. And the tool we had was a test called the hemoglobin A1C. You poke your finger and they tell you what your average sugar has been for the last 3 months. That was really important because finally we could say, wow, if you keep your average sugar down, you prevent eye disease and kidney disease and heart disease. That had to be proven. And I was fortunate enough to be part of that to say, yep, we've proven it. Good glucose control measured by the A1C matters. But now the second half of my career has been saying, that A1C era that we've lived in for the last 20, 30 years established a good control matter, but it didn't really help us get there. It just said you need to get there. Treating the average is not the best way, and that's where other glucose monitoring really comes in.
What's your assessment of the A1C era? Roughly half of people with diabetes reach recommended levels of A1C control. So is that glass half full or is it half empty? Do you see the A1C era as a success?
It was a huge success because it set in motion this striving for better glucose control. The A1C set up the need for the next technology. Why did fingerstick glucose come about? Because the average A1C said, you need to do better, but nobody wants to poke their finger multiple times a day. So A1C led to fingersticks, fingersticks led to CGM, and now CGM has changed the dialogue. A1C era had its role, but you look for the next thing to get to the next level, and that's what I see CGM as.
Well, let's get into CGMs. First, define it for us, please. What is continuous glucose monitoring?
Continuous glucose monitoring is a tool to measure your glucose values on a continuous basis. CGM measures your glucose every 1 to 5 minutes, 24 hours a day, give you alerts and alarms when you're going high and when you're going low. So think of this person poking their finger once or twice or 3 times. Now they get 288 blood sugars a day. or 1,000 blood sugars a day, and it's going to their phone. That's a lot of information. So we've got to package it. You do it two ways. One, you show a little picture of the actual curve on your phone to say, here's your blood sugar every minute. It's going up, it's going down. It shows you your picture. That's one thing. Number two, the good range is between 70 and 180. And we can tell you what percent of the time you should be there. We call that your time in range. So time in safe range or healthy range. Then it says, well, what's your percentage of time above that? And what's your percentage of time below that? We're trying to bring the highs down, bring the lows up, keep you in that good range.
CGMs are really taking off. According to Google Trends, which tracks the popularity of search terms, 6 times as many people are searching the internet for CGMs now than they were less than 2 years ago, Rich, when you and I did a webinar on diabetes care. So a 6x increase in less than 2 years. What do you make of the surging interest in CGMs?
That was a pretty powerful webinar we did, I guess. It's really taking off because you have diabetes, you want to know your glucose, but you want something that's simple, something that's accurate, something that can actually make your life better. It can tell you when you're headed low or when you're headed high. It goes straight to your phone. The other features, other people can follow your numbers. Think of the mother following their children's at school, or the spouse following their husband or wife who's off on a trip and want to be sure they're safe. This is a pretty good tool that can do all of those things.
Another point that you made at that webinar 2 years ago, October 2023, you said we're crossing a bridge from the A1C management era to the CGM management era. Why is that change happening, and what's going to be different on the other side of that bridge?
Gosh, Andy, we had some pretty big thoughts back then, but it's actually coming to be. Here we are living with the A1C. It's a great measurement tool, but it's not a management tool. Think about that for a second. It's a measurement tool, but not a management tool. We want to manage my diabetes. We want to personalize it. We've got to know minute to minute, day to day, not your average. We need to get over to using CGM on a regular basis. So how do I get across to where we're using those CGM metrics? The way to get across is to give you some way to look at your numbers. So that's one thing. It's called an AGP.
AGP, that's ambulatory glucose profile, correct?
Yeah. We want to be able to visualize numbers. An AGP gets you to say, oh, wow, A1C tells me my average. This really shows me a picture. That's number one. Number two, we can give you an estimated A1C called the glucose management indicator from your CGM. Now you start to get people say, oh, I see. I can still stick with understanding this data in the terms I'm used to, but maybe I can even learn a little more.
So we have defined CGMs, that's continuous glucose monitoring. We have defined AGP, or the ambulatory glucose profile. Can you say more about how the GMI, the glucose management indicator, fits into all of this?
The glucose management indicator, that's taking your average glucose. We measure thousands of people with diabetes or without. We can turn that average into what an A1C would be for most people. And it's called the GMI, your estimated A1C. So now clinicians say, oh, thank you for doing that. If we can use the AGP and the GMI to get clinicians and patients more comfortable with CGM. On the other side is time in range and time below range, because what you really want is not to treat to an average. You want to stay in a good range. If you're high, that puts you at risk for complications in the long term. Eye disease, kidney disease, heart disease, but you don't want to be low because that's an acute complication. That will end you up going to the hospital to get some glucose. So time in range and time below, with all these metrics, CGM can give you a lot of data. The first reports were 20 pages. You would take your CGM little device into the doctor and they plugged it in. It took about 15 minutes and 20 pages came out. We boiled that down to one page, this AGP. I've boiled it down to those two, time in range and time below range. It's just a reduction to the key things to keep us going. If you can get good time in range without time below range, you're on the right track. And the GMI is one of those metrics on the AGP report that says, if you went to the lab today and measured your A1C, this is about what you'll get because this is your estimated A1C. And if you like to talk in those terms, you can keep track of that as you go along in between your visits because that metric will continually show up. So those are terms that are helping us, I think, better manage diabetes than just having your average glucose every 3 months. And the GMI, the glucose management indicator, is a key metric to express the average glucose in percentage values like an A1C.
Critics or skeptics of continuous glucose monitoring complain about the complexity and the cost of this approach. What's your response?
People who are skeptical about continuous glucose monitoring need to just ask somebody who's worn one what they think. I've asked several thousands of people who've worn them, and it's almost uniformly, I couldn't live without this. Now that I can see my blood sugars and help guide me in my food choices and taking my medication, people with diabetes want that data. The other side of it is people who use it do better than people who don't use it. The data is pretty overwhelming. Huge studies, the largest insurance companies in the country, they look back and say, some people got CGM and some people who didn't who have diabetes. Those who got the CGM have less admissions to the emergency room, less ambulance calls, and now just published the VA, incredible system. Those who got CGM versus those who didn't had less mortality, a lower death rate over several years. Data when it's saving lives and making people feel better, I think we've got to go with it.
What about the expense?
Expense is an issue. But remember, one admission to the emergency room or hospital will cover CGM for, 100 people for a year. So you have to weigh the short and the long term. But I'm all for lower cost if possible.
CGMs are gaining in popularity, but of course, with greater awareness can come myths or misunderstandings. What do you think people don't know, or what do they get wrong about CGMs?
Sometimes people don't take full advantage of the CGM. They'd say, okay, I've got a CGM. I'll look at it here and there, or I'll bring in the data to my doctor. But if you look at that breakfast, you could try a different type of breakfast and see which is better for you. Everybody's different. So use it as an experiment. And the other thing is, retrospective or looking back at the data with your healthcare team. Sometimes that gets missed. Having a little chat with your healthcare team can be valuable to say, here's where we need to focus. We need to change your medication or focus on these lifestyles or better sleep or less stress, things like that. There's just more support we can give to make it even more valuable for people.
You have been an advisor to NCQA for a long time. What do you find the quality measurement community needs to remember when we design measures for diabetes care?
You got to measure things that matter to people and that are actionable. You got to move from measurement to management, but you don't get to the management part if you don't have the measurement part. So NCQA and other measurement organizations got to pick the key measures that matter. Diabetes has got to be on everybody's list, and thankfully it is. They've got to measure the things that patients and doctors are using so we can see if we're stacking up to our peers. I've tried to give my best advice to what we should measure and advise NCQA to go the next step in saying, now that you've measured it, let us help you manage it better. What we really want to improve your quality of life and reduce your risk of complications.
What else have you learned about translating science into sound measurement?
You got to come to the table with some data. The measurement community puts themselves on the line to say, well, I'm going to measure this, and what's the evidence that we should measure it? If 5 years ago I said, I really think you should be measuring the use of CGM, I'm not sure I could have convinced them. I didn't have the VA data to say using CGM reduces hospital admissions, improves quality of life. Now we've got the data. So when the expert panel puts that kind of data in front of NCQA and they say, okay, that makes sense, then that's good. That's a good feeling. Then it's a collaboration. We got to convince each other with the data.
You have advised NCQA on its redesigned, soon to be launched diabetes recognition program. Mm-hmm. Among the key changes in the diabetes recognition program is the addition of 3 HEDIS measures that brings the total number of measures associated with this evaluation service from 6 in the old version to 9 in the new version. The 3 new measures are statin therapy prescription, depression screening and follow-up, and, perhaps no surprise, continuous glucose monitoring utilization. Could you give us your thoughts on the addition of these 3 measures?
I'll take them in order. The statin therapy. Just think of what that means. Diabetes is much more than just your blood sugar. When you look at the ADA standards of care, there's pillars of care, and glucose control is one, but so is heart disease and kidney disease. Blood pressure and cholesterol are critical in diabetes. So if you want to get the cholesterol down, writing a prescription for a statin is number 1, 2, and 3 on the list. People with diabetes, all of them should be on a statin just because having diabetes is a high cardiovascular risk. If you've prescribed it, we know you've taken a giant step towards addressing cholesterol. So that was a really beautiful addition. We're not just about glucose, we're about the person with diabetes and all their risks.
Okay, so that's the statin therapy measure in the redesigned diabetes recognition program. The next measure that was added to the program is depression screening.
The same would be for the depression screening. We need to treat the whole person. We need their quality of life, and we need to address other than just the numbers. People with diabetes struggle with having more depression than the average person, and there's things we can do about it. So if you're not screening for it, you should, because it's a measurement that's actionable, and we have a good tool to measure it, and we have actions to follow. So that's it, the bill.
And the third measure added to the diabetes recognition program is?
The third one was continuous glucose monitoring. We had to educate each other and present the data on continuous glucose monitoring to say, was it ready for prime time? Was it ready to measure? It's indicated by all the standards of care. Everybody using insulin should be using CGM if at all possible. So we should be measuring if those who it's indicated for are using it. I really like this concept because I think that simple process measure, are you using it in your practice? All of a sudden you say, oh my gosh, when I pulled all the data, I see that these people weren't even being prescribed it. How did they slip by? Did I miss a visit? Did I forget to talk about it? So by measuring it, this critical group that everyone agreed should have it, we can now go back and look at our workflow and look at our processes. I love that measure. Right now, just measure if you're doing it, and I think it's going to make a big difference.
What have we not talked about that you think the quality community needs to know about high-quality diabetes care?
Keep looking for measures that are practical and that are actionable. Did I facilitate the change in practice, not just measurement for the measurement's sake? And then for the measurement community, can you bridge that gap? Can they create their bridge from measurement to management? They're so powerful in collecting all this data. Can they help facilitate educational efforts or ways to say, now that you've measured it, here's the partners we work with to help you better manage it. Here's how we can help you organize your clinical teams so this measurement can be put into action. So I think if they have that vision in mind, then the measurement community remains part of the greater team for improving lives of people with diabetes. Working together, we can manage diabetes. Together, we can make lives better for people with diabetes. We have the tools. We just have to work together to make it happen.
You can learn about these and other quality topics at NCQA's largest conference of 2025, the Health Innovation Summit, October 13th to 15th in San Diego. Learn more at ncqa.org/events. Thank you for listening to Quality Matters. You can always learn more at ncqa.org, and be sure to subscribe to Quality Matters wherever you get your podcasts.